Welcome to PGOG Pathways to Growth in Obstetrics and Gynecology for Postgraduates and Consultants. Today's topic is preterm labor and birth, recent concepts with including the concepts which are available in from the current year 2025. Now, so many times we do listen or we know that there are so many guidelines which are available, and why we should know about these guidelines. Various countries have their own specific guidelines, and these guidelines are designed as per the health facilities and disease presentation which is present in that particular region or country. For example, United Kingdom has two sets of guidelines. One is a government guideline by government of United Kingdom called as NICE, and other is the RCOG, which is by the this RCOG is the body of the Royal College of Obstetrics and Gynecology, which is also creating the guidelines. But now in recent years, RCOG guidelines are being converted. A majority of the RCOG guidelines are being converted into NICE guidelines. American guideline goes by the name of ACOG, Indian as FOXY. We have WHO guidelines as well as Canadian guidelines come as SCOG, Australian guidelines, and so on. So almost all countries have their own guidelines. So why we should know about all these guidelines or various guidelines is it improves our awareness about changes in the practice. Mainly, what are the changes in the practices related to the specific condition. Then, whenever we follow the guideline, especially wherever we are, it provides us a legal protection and it avoids unnecessary interventions. As the guideline changes, say for example, there are certain interventions which were practiced few years back, and now the current evidence shows that these interventions are unnecessary. So that will following the guidelines keeps us updated and it helps in avoiding the unnecessary interventions. Now, why today I have started the topic about these guidelines is this preterm labor is a topic where there is so much of difference of opinion. If we see the guidelines, there is so much of difference of opinion in related to certain issues related to this topic in the various guidelines, and there are some areas which we can call as gray areas where guidelines differ. To define preterm birth, it is the birth before completed 37 weeks or before 36 6 by 7. This preterm pre-labor rupture of membranes is PPROM, preterm pre-labor. Previously it was called as premature, but now the terminology remember that terminology has changed. It is no more called as premature, but it is called as preterm pre-labor rupture of membranes. Rupture of membrane whenever it occurs before completed 37 weeks and before onset of labor, then we call it as PPROM. Prematurity on the other hand, the terminology indicates that there is incomplete development of organ system at birth. For example, pulmonary system. Baby might have respiratory distress syndrome at birth, and it is because of prematurity. So, prematurity is related to the incomplete development of the various organs. Now, a preterm baby can be small for gestational age or large for gestational age. And according to the weight, WHO has divided or is differentiating the babies as low birth weight 1.5 to 2.5 kg, very low birth weight 1 to 1.5 kg, extremely low birth weight less than 1 kg. Now, here, this preterm birth itself, there are various categories which are given by various societies, such as American College of Obstetrics and Gynecology 2021 is dividing the preterm birth in two categories: late preterm and early preterm. Early is whenever the patient delivers before 33 6 by 7 weeks, whereas late is from 34 to 36 6 by 7. So for ACOG, there are only two categories: early preterm birth, late preterm birth. WHO, on the other hand, is dividing the preterm birth in three categories, where there is a first is a late or moderate preterm, where gestational age is greater than 32, less than 37 weeks. Very preterm, gestational age 28 to 32 weeks. Extremely preterm, whenever gestational age is less than 28 weeks. So three categories for WHO, whereas two categories for ACOG. FOXY, that is Indian guideline, is dividing the this late or moderate preterm separately in another two categories. So there are total four categories with moderate as 32, moderate preterm 32 to 34 weeks, late preterm 34 to 37 weeks. Definition and terminologies related to the preterm labor. Preterm labor can be either spontaneous or induced, such as for severe preeclampsia, if we induce labor, that is induced preterm labor, or it can be spontaneous. So definition for spontaneous is if there are regular uterine contractions and the number of contractions is greater than or equal to 6 contractions in 30 minutes with a cervical dilatation of greater than 2 centimeters as per ACOG, or greater than 3 centimeters as per various other guidelines, and it should be between 20 to 37 weeks of pregnancy. We call it as established preterm labor whenever dilatation is greater than 4 centimeters. Threatened preterm labor is when there are uterine contractions without necessary cervical dilatation of 2 centimeters or 3 centimeters. Diagnosis of preterm labor with intact membranes. We have to take careful history. We have to do per abdominal examination, mainly to know the number of uterine contractions per hour. Per speculum examination to be done to rule out whether there is a rupture of membranes by presence of amniotic fluid. And per speculum, we can even visualize cervical dilatation. And if it's a through dilated cervix, sometimes we can see the bulging membranes also on per speculum examination. Now, if necessary, and if there is a practice, depending on our own guideline or departmental guidelines or hospital guidelines, if there is a practice of taking fibronectin test, taking swab for fibronectin test, it should be taken before we proceed with per vaginal examination. So after per speculum, take a vaginal swab and then only go for per vaginal examination to see for extent of dilatation, effacement station. So this per vaginal examination to be done only after taking a swab for fibronectin test if it is found necessary, and after ruling out placenta previa. Regular contractions with cervical dilatation of greater than 2 centimeter indicates that it is a case of preterm labor. So same thing here, per abdominal examination, per speculum, if necessary to take a swab for fetal fibronectin first and then only proceed for per vaginal examination is the important concept. If clinically suspected preterm labor is there, where the dilatation is still not beyond 2 centimeters, but there is a suspicion whether patient is going for preterm labor, and if patient's gestational age is greater than 30 weeks, then the next step to be done is to diagnose preterm labor is to go for transvaginal sonography to measure the cervical length. Cervical length less than or equal to 15 millimeter is gives us a diagnosis of preterm labor. Greater than 15 millimeter, we have to search for other conditions as differential diagnosis for patient's presentation. Gestational age greater than 30 weeks, and if for some reason TVS is not possible, then we have to go for fetal fibronectin test. So first investigation of choice in suspected preterm labor to confirm the diagnosis is always transvaginal sonography and measurement of cervical length. But for some reason this is not feasible or possible, then only we have to go for fetal fibronectin test. Fetal fibronectin concentration greater than 50 nanogram per ml indicates preterm labor. Less than or equal to 50 nanogram per ml, then we have to consider other conditions as differential diagnosis. If both TVS or fibronectin tests are not possible, if both are not available or it is not possible to do any one of these two, then treat the patient as a diagnosed case of preterm labor whenever there is a suspected preterm labor. We should never combine TVS and fibronectin for the diagnosis of preterm labor is an important concept which is given by NICE guideline. So here the same thing is there, that for a cervical length cutoff is 15 millimeter, whereas for fetal fibronectin, it is 50 nanogram per ml. Now, what is this fetal fibronectin is? It is a extracellular matrix glycoprotein which is present present at decidual chorionic interface. It is released in cervicovaginal secretions whenever extracellular matrix is degraded, and this extracellular matrix degradation takes place in many situations leading to preterm labor. If there is bleeding, or if we have already done pervaginal examination, or if there is a recent history of intercourse, then these conditions can lead to false positive fetal microfibronectin test. That is the reason swab for fetal fibronectin needs to be taken before performing pervaginal examination. Now, this advantage of fetal fibronectin test is it has high negative predictive value. That means test is negative, it is less likely that patient will have proceed with a preterm labor, but it has a low positive predictive value because of the high possibility of false positive result. And this is the reason it has a lower clinical utility, and that is the reason we have already seen that first investigation of choice in suspected preterm labor where diagnosis is uncertain is transvaginal sonography to measure cervical length and not fetal fibronectin. It is also not freely available everywhere, and comparatively it is an expensive investigation. Now, for diagnosis of PPROM, pooling of amniotic fluid is seen on speculum examination, and once we see the amniotic fluid, there is no need for further testing. But if it is not visible amniotic fluid, then we have to go for rapid non-invasive test. For that, we have two tests which are based on the detection of proteins which are present in the amniotic fluid. First is the insulin-like growth factor binding protein 1, insulin-like growth factor binding protein 1, and other is placental alpha microglobulin 1 test. Either of these tests can be performed. Now this is bedside strip test which can be done. This insulin-like growth factor binding protein 1. It is a protein which is present in amniotic fluid. Bedside strip test can be done. It has high negative predictive value. It is available in India. Now, this PAMG is placental alpha microglobulin 1 test. This is also a protein which is present in amniotic fluid. It has greater diagnostic accuracy, 99% diagnostic accuracy with this PAMG1. Comparatively, it is a expensive test. Now, nitrazine tests, foreign tests are at present not recommended by current guidelines, especially NICE guideline does not recommend these tests because of the low sensitivity and specificity. These were done in the past quite frequently. This nitrazine test or foreign tests, and these are not being advocated at present by NICE. Now, if there is no need of testing, if PPROM is associated with established preterm labor, establishes whenever cervical dilatation is greater than 4 centimeters, then we don't have to go for these investigations. Now, to know foreign test and nitrazine test, these are the traditional diagnostic tests which were used to diagnose the PPROM. These are replaced now by better tests because of better accuracy. Results are affected by presence of infection or any infection in the vagina, vaginitis, or even blood. But still, it has some place in low resource settings wherever these other tests are not available. What is seen is a fern pattern on dried amniotic fluid under low power microscope. It is because of the presence of estrogen in the amniotic fluid. Or with the nitrazine, there is a change in the pH. pH is from yellow acidic, it becomes blue alkaline. Blue color is indicative of a presence of PPROM, diagnosis of PPROM. But both these tests are, there is a low sensitivity and low specificity. Coming to prevention of preterm labor, what is the place of prophylactic progesterone as per NICE 2022? We can use vaginal progesterone as prophylaxis to prevent preterm birth. Now, for this use of vaginal progesterone, according to NICE 2022, it should be started with a presence of any one of these three indications. First is if there is a history of spontaneous preterm birth at less than 34 weeks in previous pregnancy. Specifically, I have made this as spontaneous because if there is a history of induced preterm birth, say for severe preeclampsia, then there is no need to start this prophylaxis to prevent preterm birth in subsequent pregnancy. It is only indicated whenever there is a history of spontaneous preterm birth in previous pregnancy or history of spontaneous loss of greater than 16 weeks, which is suggestive of cervical insufficiency. Or third is if transvaginal sonography is done between 16 to 24 weeks to measure the cervical length and cervical length is less than or equal to 25 millimeters, then also we can start this vaginal progesterone um, to prevent preterm birth. Normal length, cervical length is 35 to 48 millimeters. This is started as vaginal progesterone capsule 200 milligram per day from 16 to 24 weeks till at least 34 weeks. But the current emerging evidence in 2025 article, it shows that about this third indication, that if there is only a short cervix, whether we should start vaginal progesterone. There is a question mark about the role of vaginal progesterone with only a short cervix as per this article given by American Review article, which I have given it at the end of the presentation in the references, that whether it is really necessary to give it only for a short cervix without history of previous spontaneous preterm labor. There is a doubt about it, whether it really prevents the preterm birth, whether it is really necessary, and whether it improves the obstetric outcome. That is why there is a question mark about it. That is the emerging evidence. Prophylactic cervical cerclage, as per NICE 2022, it needs combination of two situations. Cervical length should be less than 25 millimeters at 16 to 24 weeks, along with history of PPROM in previous pregnancy or history of cervical trauma. Now, as per ACOG, prevention of preterm birth remains an elusive goal. It is possible only in selected cases. We can't prevent preterm birth in all cases. Indications for cervical cerclage are history of second trimester loss with history strongly suggestive of cervical insufficiency, such as there is a painless cervical dilatation in after 16 weeks of pregnancy and patient is having a very fast delivery, quick delivery, almost painless cervical dilatation, where it is preceded by rupture of membranes. All this is suggestive of classical case of a cervical insufficiency. Or ultrasonography showing a short cervix less than 25 millimeters with history of prior spontaneous preterm birth. So ACOG is giving these two indications. There is no role of cervical cerclage if there is only short cervix. Without history of spontaneous preterm birth, we should not be going for a cervical cerclage. Rescue cerclage is whenever it is done in emergency in treated preterm labor. Multiple pregnancy, there is a conflicting evidence at present, and there is no clear evidence whether the cervical cerclage helps in cases of multiple pregnancy. All these, whatever ACOG is giving us, all these are associated with singleton pregnancy. So to clear the confusion, as we have seen in the first slide only, that guidelines will differ in many areas related to this topic, and this is one of the topic where there is a difference in NICE guideline and ACOG guideline. What are the indications for prophylactic vaginal progesterone? What are the indications for prophylactic cerclage? For vaginal progesterone, NICE says any of these three: history of preterm birth, short cervix, or a history of loss greater than 16 weeks. ACOG, on the other hand, is specifically telling us to start vaginal progesterone if there is history of preterm birth along with short cervix. That is the difference. Secondly, for prophylactic cerclage, NICE says that there has to be a history of PPROM or cervical trauma along with short cervix. So now here carefully appreciate that ACOG is going for short cervix with history of spontaneous preterm labor, whereas NICE is going specifically for PPROM only, not for preterm labor. So prophylactic cerclage as per ACOG, we can do it with second trimester loss and cervical insufficiency, or we should be going it do it for short cervix with history of spontaneous preterm labor in previous pregnancy. Now, as per 2025 current evidence, there is no role of routine cervical length measurement in low risk cases. The cervical length measurement from 16 to 24 weeks should only be done whenever there is a history of spontaneous preterm labor in previous pregnancy. And there is no role of injectable progesterone. So 17 alpha hydroxyprogesterone, we were using it quite frequently, but now the current evidence 2025 tells us that there is no role of injectable progesterone in prevention of spontaneous preterm labor. Now we come to the next controversy related to this topic, that is corticosteroids in preterm labor. The effect of corticosteroid, it takes place from 48 hours of administration, and the effect remains for 7 days of administration. It leads to improved perinatal outcome by reducing RDS, intracranial hemorrhage, necrotizing enterocolitis. Single course of either betamethasone or dexamethasone is indicated. Betamethasone with a dose of 12 milligram 24 hourly. Two such doses are to be given intramuscularly, and the salt should be sodium betamethasone sodium phosphate with acetate. Dexamethasone is given 6 milligram 12 hourly, 4 doses intramuscularly. Now this is important, that is why I have given the red color here. We should be aware of betamethasone salt whenever you are administering betamethasone. If it is the salt is containing only betamethasone sodium phosphate and there is no acetate, then it is a short acting salt. I have already covered this in the separate video which is available at PGOG on corticosteroids in pregnancy, but because it is important, I am repeating once again that if it is a salt is having no acetate, it is containing only phosphate, sodium phosphate, then in that case it is a short acting betamethasone which needs to be given 6 milligram 12 hourly for 4 doses. Especially in India, so many places this betamethasone which is available is containing only sodium phosphate. Now this corticosteroid administration, it needs to be initiated even if there is a possibility of incomplete treatment, even if you know that patient might deliver before the next dose. Clear indication for corticosteroid use in preterm labor is from period of viability to 34 weeks. Rescue in single course can be given if the previous corticosteroid administration is of the duration is of greater than 7 days and gestational age is less than 34 weeks. Is that means repeat second dose can be given. Suppose we have given first dose and patient fails to deliver for say 10 days and now she is going in preterm labor. So the administration was of greater than 7 days. One more dose of corticosteroid can be repeated, that is called as rescue single course. Now the doubtful situation is whenever the gestational age is peri-viable, that means up to 22 weeks, as less as 22 weeks. So the decision to give corticosteroid will depend on mainly the neonatal facilities, and greater than 34 weeks it is a gray area, guidelines differ. So why limited or dose use of corticosteroids as per the recent guidelines, especially to there was a big trial which was conducted in 2022 which has questioned the use of corticosteroids in late preterm deliveries, especially after 34 weeks of pregnancy, because the study showed that corticosteroid use increases neonatal hypoglycemia, and that too in women having diabetes mellitus. Then long-term metabolic effects of corticosteroids are not known, and it might increase the mental and behavior disorders when given for late preterm babies is another evidence which has emerged. And because of these serious effects of corticosteroids on fetus, there is now a cautious approach about whether to give corticosteroid after 34 weeks. So if we see all the guidelines, what we see is greater than 34 weeks, what ACOG says is consider giving after counseling. You tell the patient about all the current evidence and take a shared decision about giving corticosteroids from 34 to 36 6 by 7. ACOG clearly says it should not be given whenever there is a pre-gestational diabetes mellitus, complicating pregnancy, or whenever there is a presence of intrauterine infection. Now, coming to NICE says that you consider from 34 to 35 by 6 by 7. It is not mandatory. We can consider, and case to case we can discuss and take a decision. FOXY Indian guidelines says that from 26 to 33 6 by 7 we should be giving it, but from 24 to 26 again we have to consider. That means it is depending on the possibility of survival, depending on the facilities which are available at that place for the survival of the babies from 24 to 26 weeks. RCOG says offer till 34 6 by 7. So this is the difference at present between NICE and RCOG. NICE is going up to 36, RCOG is going up to 35. Canadian guideline consider from 34 to 37 weeks. WHO says you give it from 24 to 34 weeks clearly. It should not be given if there is chorioamnionitis, should not be given for planned caesarean section from 34 to 37 weeks is the WHO guideline. So that is how there is a gray area or confusion, and then we have to take a decision according to wherever we are, whatever are the, suppose you are in working in a department, you should have departmental guideline whenever such gray areas are there. Or in a hospital you are working, you should have a hospital SOPs, standard operating procedures, so that you can follow those. That gives a uniform advantage to all the cases, as well as it provides you with a legal protection. Now coming to tocolytics in preterm labor with intact membranes, indications for short-term use are for intrauterine transfer. Suppose patient goes in labor at a place where neonatal facilities are not there, and you want to transfer the patient to a better facility, then for short-term use, then tocolytics are indicated, and for completion of corticosteroid course, which usually takes around 36 to 48 hours. Contraindications for the use of tocolytics are if there is a bleeding PV, if there are features of intrauterine infection, if there is severe preeclampsia which necessitates immediate delivery, if it is an intrauterine death or major congenital malformation in the baby, or if there is a severe maternal cardiac disease. Long-term use of tocolytics is not recommended as there is no improvement in perinatal outcome, and these tocolytics are associated with serious side effects. So whenever we talk about tocolytics in preterm labor, it is mainly for short-term use for up to 48 hours usually. Various tocolytics are calcium channel blockers or inhibitors. The drug which is commonly used is nifedipine. Cyclooxygenase inhibitors, COX inhibitors, indomethacin. Beta mimetics, the commonly used drug is terbutaline. Oxytocin receptor antagonists, Atosiban. Magnesium sulphate, and nitric oxide donors are nitroglycerin, but it was studied as a tocolytic, but it is not used because of the low efficacy and because the better drugs are available. As per NICE, first tocolytic of choice whenever you want to use tocolytics in preterm labor with intact membrane is nifedipine. Offer nifedipine from 26 to 34 weeks. Consider it from 24 to 26 weeks. Nifedipine is contraindicated. Then, in a patient, whenever nifedipine is contraindicated, go for oxytocin receptor antagonist. Beta mimetics should not be used, is the clear statement given by NICE 2022. Now, nifedipine is given with a dose of 20 milligram at 0 hour, and then it is followed by 10 milligram 6 hourly. Its side effects are mainly because of peripheral vasodilatation such as dizziness, palpitation, flushing, nausea, tachycardia. It is contraindicated whenever there is a maternal hypotension and whenever the patient has a heart disease which is preload dependent such as aortic stenosis, mitral stenosis. Now, why NICE says that you should not be using beta mimetics or even indomethacin has not been recommended by NICE is indomethacin leads to constriction of ductus arteriosus and oligohydramnios, especially if it is given for more than 2 to 3 days. Terbutaline has lower efficacy as a tocolytic as well as safety issues are there. It leads to tachycardia, hyperglycemia, and that is why it is also not recommended. Oxytocin receptor inhibitors at Atosiban needs infusion pump. It is the second drug of choice as far as NICE guideline goes. Dose is given in 3 stages. First at 0 hour, it is given as IV bolus 6.75 milligram. Next 3 hours, it is given with a dose of 300 microgram per minute. And then for 45 hours, it is given as 100 microgram per minute. It should not be given for more than 48 hours. Main advantage is safety. Its only contraindication is anaphylactic reaction to the drug. It has minimal side effects. Only side effects are it is given intravenously. So at the injection site, there can be uh, side effects because of the thrombophlebitis and like that. But main problem is it is expensive and not readily available. Now, magnesium sulfate as a tocolytic as well as neonatal neuroprotection. Magnesium sulfate is given as a second line because of its potential to cause serious maternal side effects. It is preferred as a tocolytic in established preterm labor at 24 to 30 weeks as a neuroprotector. So, tocolytic as well as neuroprotector, it is preferred from 24 to 30 weeks as per NICE guideline. It can be considered from 23 to 24 weeks and from 30 to 34 weeks. So best period which is given is 24 to 30 weeks for neuroprotection. Whereas WHO and ACOG guidelines says that magnesium sulfate should be used for neuroprotection up to 32 weeks. It reduces cerebral palsy, it reduces the incidence of severe intracranial hemorrhage, and it provides neuroprotection. If necessary, if magnesium sulfate is being given as a tocolytic as well as neuroprotector and still persistence of uterine contractions is there, you can add indomethacin to magnesium sulfate for tocolysis. But remember that we cannot add nifedipine, we cannot add terbutaline along with magnesium sulfate because this combination can lead to profound hypotension and profound respiratory depression. It is given with a magnesium sulfate is given with a dose of 4 gram intravenous bolus over 15 minutes followed by with an infusion pump IV infusion 1 gram per hour for 24 hours or till delivery whichever is sooner. Whenever patient has any renal disease then the dose needs to be reduced. Its main disadvantage is it needs careful monitoring for magnesium sulfate toxicity, 4 hourly blood pressure, respiratory rate, urine output and deep tendon reflexes. Its main advantage is it provides neuroprotection in preterm babies, especially less than 32 or 30 weeks. Main contraindications are myasthenia gravis and heart block. So magnesium sulfate for neuroprotection in established preterm labor, WHO strongly recommends it up to 32 weeks. ACOG also recommends it up to 32 weeks. NICE says that it should be given up to 30 weeks, 24 to 30 weeks, and we can consider from 23 to 24 and from 30 to 34 weeks. That is how there is a difference in the guideline, that NICE is confidently advising to give Maxel for neuroprotection up to 30 weeks, whereas WHO and ACOG are strongly recommending it up to 32 weeks. Antibiotics in preterm labor, these are indicated for all preterm labor cases as far as a NICE guideline goes, mainly as a group B streptococcus GBS prophylaxis. And it also needs to be given whenever there are features of chorioamnionitis in a case of preterm labor. Choice of antibiotic is benzyl penicillin can be given. If there is a history of mild allergy, cefotaxime can be given as GBS prophylaxis. But if benzyl penicillin and cefotaxime allergy is there, then the next drug is vancomycin. Whenever there is a chorioamnionitis, we have to add gentamicin and metronidazole to these drugs. What is important is to know that an intrapartum amoxicillin clavulanic acid should be avoided as it increases the neonatal necrotizing enterocolitis rate. Management of PPROM, prophylactic antibiotics are to be started. Oral erythromycin is the drug of choice, 250 milligram 4 times a day. Antibiotic is continued for 10 days or till established preterm labor. Monitoring to diagnose intrauterine infection in PPROM forms the main stay in the management. And for that early diagnosis of chorioamnionitis, we have to do various tests which include C-reactive protein, WBC count, and we have to do the fetal heart rate monitoring by doing a CTG. Now remember, no single test helps in diagnosing infection. Whenever we are using these, we have to take into account the result of all these, and then only we have to come to a conclusion. Because for chorioamnionitis, unfortunately, fever is the only reliable indicator. Whenever fever is greater than 100.4 degrees Fahrenheit, then we diagnose it as with confidence as chorioamnionitis. For early diagnosis, when we go for all these three tests, C-reactive protein, WBC count, and CTG for fetal heart rate, we have to consider all these three together for the early diagnosis. Now, it is very important to be cautious to diagnose chorioamnionitis, because once you diagnose, there is no role of expectant management, and we have to proceed with a decision for immediate delivery. Now, for management of PPRM, there are two modes of management as per the gestational age. Either we can go for expected management or intentional delivery. Now, expected management is specially indicated from 24 to 34 weeks of pregnancy with a PPRM. We can consider expected management from 34 to 37 weeks. But if there is chorioamnionitis, CTG abnormality, or features of placental abruption, any of these will be an indication for immediate delivery. Management whenever a patient is in preterm labor, CTG monitoring for fetal monitoring. We should avoid scalp electrode use or fetal blood sampling, especially when our gestational age is less than 34 weeks. GBS prophylaxis and that is antibiotic and magnesium sulphate, whenever indicated, it needs to be continued as indicated throughout the labor. Cesarean section is indicated for preterm breech. Whenever cesarean section is indicated in preterm birth, what we need to understand is the incision the transverse incision in the lower segment might be a very small incision. There can be difficulty in delivery of the baby, and we might have to take a decision to proceed with a lower segment vertical incision with its complications in subsequent pregnancies, such as extension to upper segment and more possibility of a scar rupture in the subsequent pregnancy. Delayed cord clamping is advocated in preterm labor, where the cord clamping should be done after 30 to 60 seconds. To summarize, Use of corticosteroids for in preterm labor. There is a consensus by all the guidelines that there is a place to use corticosteroids to improve the perinatal outcome whenever gestational age is between 24 to 34 weeks. All the confusion is whenever gestation age is greater than 34 weeks, from 34 to 37 weeks. And the main reason is because there is a emerging evidence that corticosteroid has adverse neonatal effects. Effects on the fetus are there, such as there is increase in neonatal hypoglycemia, and we are not aware about the long-term metabolic effects of corticosteroids on the babies, as well as there is a possibility of increase in behavioral or mental problems in the babies. Because of all this, there is a concern about the use of corticosteroids in late preterm births after the gestational age of 34 weeks, and that is why the guidelines differ on this point. For magnesium sulfate use as a neuroprotection, NICE guideline says that it can be used up to 30 weeks, whereas WHO and ACOG are recommending it at present up to 32 weeks. So there is a difference of opinion here also. Antibiotic use for GBS prophylaxis is recommended by all the guidelines in all cases of preterm labor. Now, there is a again difference of opinion about the prevention of preterm labor by the use of prophylactic cerclage, whether it should be done whenever there is a short cervix with PPROM or short cervix with preterm labor. At present, NICE says that we need to have a history of PPROM and presence of short cervix to perform prophylactic cerclage, whereas ACOG says that indication to do the prophylactic cerclage is presence of a short cervix with previous history of spontaneous preterm labor. That is how there is a difference in the opinion in the guidelines. For vaginal progesterone, NICE guideline says that it can be used to prevent preterm labor if there is a previous history of spontaneous preterm labor or there is a short cervix. Whereas ACOG says that there has to be a combination of these two to initiate vaginal progesterone. About PPRM, there are two ways we can manage the patients. One is expectant management and other is intentional delivery. Expectant management is there is a place whenever gestational age is between 24 to 34 weeks. Intentional delivery is indicated whenever there is a chorioamnionitis, possibility of placental abruption, or there is a fetal heart rate abnormalities, then the immediate delivery is indicated. Otherwise, after the age of gestational age of 34 weeks up to 37 weeks, we have to decide according to the individual case whether to proceed with the intentional delivery or expected management. Thank you so much. The main reference is this. This is Stratfol's preterm labor. I have given this reference, and if further details you want to read more in details, you should visit this site. NICE Guideline 2022 has helped me a lot. Williams Obstetrics and Foxy Guideline. Thank you once again.